Hello, everyone. Welcome back to the Ave Maria Press Professional Development Webinar Series. In this webinar, Dr. Natalie King will explore the complexities of end-of-life care from a Catholic viewpoint. My name is Erin Pierce. I am the publicist at Ave Maria Press. Everyone in the audience is muted today, but you are able to ask questions. Questions may be sent to our presenter using the question section on the GoToWebinar panel, and I'll read as many of those as possible at the end of the presentation today. This webinar is being recorded, and a link to the recording will be sent to you via email tomorrow. With that, I would like to welcome and introduce our presenter today. Natalie King, MD, is a palliative medicine physician who cares for patients with serious illness and those nearing the end of life. King writes and speaks nationally, educating about and advocating for the expansion of palliative medicine as the surest way to safeguard human dignity in serious illness and end-of-life care. After finishing her medical training, King worked as a palliative medicine physician for several years at a hospital in Colorado, where she led the hospital's ethics committee and helped teach trainees. She partnered with the USCCB to improve education for Catholic laity about palliative care and organized a forum for the Catholic Medical Association on end-of-life issues. King holds a Bachelor of Arts in Anthropology and Pre-Professional Studies from the University of Notre Dame, a Master of Arts in Bioethics from the Ohio State University College of Medicine, and a Doctor of Medicine from Tulane University School of Medicine. Natalie, thank you so much for joining us today.
It's wonderful to be here, Erin. Thank you for having me.
Absolutely. I'm going to go ahead and make you presenter.
See. Can everyone see my screen?
Now we can. Yes.
Right.
Yes.
Okay.
All
perfect.
right. Let's take it from here.
Thank you, Erin. Hello, everyone, and greetings from snowy Utah, where we're getting a touch of winter today. It's such a privilege to be here with you, and a real joy to share this with you. I love using this image of a sunset that I have on my slide here to demonstrate the beauty that I get to see as I care for patients who are nearing the end of life and dealing with serious illness. For the most beautiful time for a sky is just before it darkens and the light of the sun is extinguished. And likewise, there is so much beauty that I discover in each person I meet, encountering them in the richness of their personhood as I care for these patients as they near the end of their earthly life. It's a real joy and a privilege, and I'm excited to share more about this field with you today. If you wouldn't mind joining me for an opening prayer. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. God of compassion, you willingly took on our human condition to experience the same pain, suffering, and death that we do. Through your Son's resurrection, you transformed suffering and death into new life and glory, and invite us to join our own pain and struggles to those of Jesus. Increase the faith and hope of all who are suffering, especially those living with chronic illness and pain. Strengthen and confirm in them the promise of new life and glory. We pray this through the intercession of Our Lady, and in the name of your Son, Jesus, and the Holy Spirit, now and forever. Amen. In the Father, and the Son, and the Holy Spirit. Amen. And I offer this talk today for all those dealing with serious illness and their families. So a few disclosures. I'm Catholic, you probably guessed. I love my faith, and I'm excited to share how my faith connects with my profession. I'm passionate about advocating for the sanctity of life, especially when it's nearing its earthly end. And I'm passionate about particularly sharing how palliative medicine can provide for those dealing with serious illness and at the end of life with dignity that is completely consistent with Catholic teaching. Just to note, these views presented in the presentation today are of those of mine personally and not necessarily those of my employer. So I went to medical school, like most people, to figure out what was wrong with patients and to diagnose to help restore someone to health. So how did I get into a field where the patients I typically care for can unfortunately not always be cured? So my faith has always been tied to my professional work, and I've been Catholic my whole life. And in college at Notre Dame, I grew a lot in my faith. When I went to medical school, I was not in a Catholic school, and I was really challenged by others who looked at me and asked questions about what I was claiming to believe. And when push came to shove, there were times that I could not explain it. I was not good at defending my faith. And I really came to this crossroads because I had a Catholic identity, but what did that mean? I knew what I was supposed to believe. I knew I had the prayers memorized. But I really had to understand the why behind this. And so I did a lot of soul searching and reading. And with the help of a great spiritual director, I had to reform myself stronger in my faith because I was entering a profession where I had to choose to actively, not passively, live my Catholic faith. Otherwise, I could choose something else. Because for me, I couldn't choose just to be Catholic on Sundays and be something else the rest of the week. I needed to be Catholic every day. And so this brought me to this million-dollar question that I was facing. Could I truly live authentically as a Catholic in today's healthcare system? Could I live out the professional vocation that God was calling me to consistently according to the church's teachings? And this was really amidst this grave reality of so many issues that were being brought up in the classroom and I was hearing about in the news. And I was really discouraged at times about the state of medicine today and the perspective that was being presented to medical students, the pressure that everybody is doing it, that if you're not doing these things, that you're not doing the standard of care. The world says to involve oneself in these things and to bend or change your beliefs. Yet I had this profound realization that these vulnerable bodies and souls of patients who are coming to me for care, they were in my hands. And in a real direct way, my soul was on the line for the care I provided or I didn't provide. And I had direct impact over others' lives, and I would have to account for this at the end of my life. So the gravity of this was real. At times, I felt like this at this puppy because in the world today, it's easy to feel discouraged. And I'll tell you, as a newly minted palliative care physician, my first job out of training brought me to a new state. 2 months after I moved there and started my job, and it was the very day, if you can believe it, after I took my big palliative medicine and hospice board exam, physician-assisted suicide passed into law and became legal in that state. And I wept. This state voted to legalize physician-assisted suicide. What did this mean for me as a doctor, specifically as a palliative doctor, as a Catholic, and as a human being? It's hard to know our Catholic Church teachings and to not see them practiced in the workplace, where life may not be held as sacred, where people are considered burdens, where suffering may not have any meaning. And as a patient, it can be really hard to trust the healthcare system. I understand. The world we're in currently is a crazy place. Yet it was through this particular time and this particular place that God placed me where I was faced with this huge opportunity and how I could try to shed God's love in the midst of it. And so I began learning more about ethical issues to get involved in my hospital and healthcare system. And I began to speak on end-of-life issues as a Catholic doctor. The questions I receive at the bedside and the presentations I've given, they demonstrate to me that many people are struggling. They're trying to navigate the healthcare system as best they can in the setting of a lot of stress, perhaps serious illness or that of a loved one. And they're also trying to adhere to their Catholic faith. And that's really what brought me to write the book, Intensive Caring. It's because I want to help. So let's talk a little bit about palliative care. When I first went into it, a lot of people didn't know what it was when I would tell them that this was going to be my specialty. And it comes from the root word pallium, which means to cloak. And you might think, okay, that's kind of weird, but who wears the pallium is the Pope. So this is an intrinsically Catholic thing. And you think about a cloak that it's around your shoulders, it helps keep you warm, it gives you support. And that's really what palliative care is meant to do. Amidst all the stresses that are out there in healthcare, we're here to be a support all around you, to help support you in any stress you come across. This is a definition I like. Palliative medicine is a type of specialized medical care for people with serious illness. And so when you think about serious illness, that doesn't just mean that a particular thing, a particular diagnosis. It can be cancer, it can be a stroke, it could be something like MS or Parkinson's disease, it could be heart failure, chronic kidney disease, but it's basically anything that's causing a lot of stress in your life. It's something that might give you a lot of symptoms or pain, so it's really whatever the diagnosis is. Palliative care's goal is to work to improve what you perceive as your quality of life, like what makes you live the best life possible. We're helping you, but also those who love you, your family members, because we know that serious illness affects all those who you know. We're working with you to help care for you alongside your other care providers. So you don't lose any of your other doctors. You get to have an extra team to provide another layer of support. Palliative care is appropriate at any age. They have palliative care for children, adolescents, adults, and palliative care is helpful at any stage in a serious illness. So we're a support team that walks with you. It can be right at the time of diagnosis, or it could be perhaps when a relapse happens, or just a really stressful time, like your caregiver had a health issue and can't care for you like they could anymore, or whatever is going on. But we provide care together alongside curative treatment. So palliative care doesn't take anything away. It just helps you live as long as possible, as well as possible for as long as possible. That's what we really say. And palliative care can happen in the hospital. That's where I work. But it can also happen in clinic settings, or it can be even in the home-based sort of visiting home care kind of setting. So when I approach new patients, I work with a team, and I have often nurses, social workers, or chaplains that work with me, because we know that there's lots of different aspects of stress. And we work to really look at the whole person and the physical symptoms they're experiencing, any psychological or spiritual distress, social issues, and again, for any age, helping them along the way. And I really try to look at a patient as not just them with a disease, but who would they be outside of the clinic or the hospital? Tell me about who you are. Tell me about how you would like your doctors to see you. And oftentimes I have family members bring in a photo of the patient and how they would like to be seen by their medical team. And it's really meant to provide a humanizing touch to the rest of their care team. And it's a really beautiful, I just love it. It's a beautiful way to care for people. And so what does the Catholic Church say about palliative care, you might want to know? It really is meant to be encouraged. Palliative care is an authentic expression of the human and Christian activity of providing care, the tangible symbol of the compassionate remaining at the side of the suffering person. Its goal is to alleviate suffering in the final stages of illness, and at the same time to ensure the patient appropriate human accompaniment, improving quality of life and overall well-being as much as possible and in a dignified manner. And I love this quote, and I like to highlight the word accompaniment, because that's really what I'm here for and what my field is. We're meant to walk with you, to be with your family, to not abandon you as you're dealing with serious illness and stress. And that's a beautiful kind of way to think about it. That quote was from this document called Samaritanus Bonus, and that means the Good Samaritan. This document, Samaritanus Bonus, on the care of persons in the critical and terminal phases of life, is a church document that came out in the year 2020. It came out from the letter for the Dicastery for the Doctrine of the Faith at the Vatican. And this is one of the oldest departments at the Vatican that was founded to defend the Catholic Church from heresy. And it's the body responsible for promulgating and defending Catholic doctrine. So basically, this document looks at all these issues around serious illness and the end of life, and particularly in our current culture and what's happening, and really works to refute certain things that are happening and to defend and claim what the Catholic Church teaches about it. It's a wonderful document, and it's for all those who come into contact with the sick and the dying, those in healthcare, but also family members, priests, and other pastoral workers. It clearly delineates beliefs and how these are practiced. It's very practical, and I really believe this document is a wonderful thing to read. It's very needed, and it's a beautiful description of our faith around the end of life. So it's very pertinent to me personally in my profession. Cicely Saunders is a founder of the palliative care and hospice sort of model, and she coined this term total pain. And it's all the encompassing physical, emotional, spiritual, and social suffering experienced by patients experiencing serious illness or nearing the end of their life. And she says, you matter because you are, and you matter to the last moment of your life. We will do all we can, not just to help you die peacefully, but also to live until you die. And that's really the whole point of palliative care. It's about your living. We're not just talking about your end of life. It's about how you live the best you can with what you've got going on in your health. And so how should pain be managed? Cicely Saunders is talking about total pain. And I think it's important to know the church teaches that adequate pain management is important. When we think about pain management and any sort of sedation or making people sleepy because of a pain medication, we think about something called the principle of double effect. And I have patients come to me all the time and they're really worried about taking something like opioids or a pain medication. And honestly, those medications, and if used in a safe manner, are very appropriate. And honestly, the gold standard for treating some things like cancer pain or difficult shortness of breath in the setting of heart failure or lung disease. And as palliative care physicians, we're trained to really manage these very safely. We start low and we increase slowly to effect. But my goal is to help relieve that patient, take the edge off that patient's distress so that they're not having pain to where they can enjoy a conversation with loved ones or get up and walk to the bathroom or whatever's been impacting them that's making life so difficult. And my intent in giving a pain medication is never to sedate a patient. I always want them to have as clear of mind as possible. And so that's kind of what I'm thinking about here in this principle of double effect, which is an ethical principle. When we think about looking at distress in palliative care, we know that it's not just physical pain we're dealing with, but psychological, social, and spiritual pain. And I have this slide up because I laugh. My consultations are never like a linear process. I tell my team it's often improvisation. When we enter the room, we're really here to answer the patient's agenda, to say what distress is going on in your life and how can we help address it. Sometimes it's the chaplain that really takes the lead or the social worker. And often it's physical symptoms that I can help address as a physician. So we all work together to help manage patient distress. And as I'm listening to patients and hearing about the distress in their life, I'm really trying to get a sense of their subjective, like how their life is going in their opinion. And I ask them to tell me, where is your life? Like, how do you feel your life is going from a 1 to a 10? 10 being the best life ever, 1 being things are just in the pits. And if they tell me it's a 2, I'm like, okay, how can I get you to a 3 or a 4? How can we just up the scale a little bit? Or if it's like an 8, how do I get you to a 9? That's really what we do in palliative care. We're creatively looking at how to decrease suffering. And so suffering, as we know, comes in many forms. Physical suffering is the most straightforward. You think about from the side effects of the treatment or the disease itself. Emotional suffering, I think depression and anxiety are really common in serious illness, and people are dealing with a lot. Maybe they're not able to do what they used to. They feel that they're a burden to their family, or they feel really angry about what's going on. Perhaps the illness has brought out a lot in their family. People are coming out of the woodwork for better or for worse, and it's a lot of stress. There's just a lot going on emotionally, and it's important that we address this too. Social suffering is also something important that often we don't think about to address, but as patients are dealing with serious illness, they may have a changing role in their family or community where they're not able to participate in the same way that they could before. They might not be able to go to work anymore. They might feel like they're withdrawing a bit because they're embarrassed because maybe they've gained a lot of weight or lost a lot of weight from their disease, or maybe their hair has changed. They might be unable to fulfill commitments that they've always defined themselves and prided on themselves being able to do in the past. And so serious illness can be really exhausting in many ways, but often it can be very poor to relate to others. And people want to help, but they don't know how. And so this isolation is something that we also work to address. Financial suffering is something that's common, but often not discussed. And this is something that my team, I just try to bring it up in a very non-judgmental, open way to see if this is something on the mind of the patient. So many times this disease really blindsided them and their families, and they're unsure how they're going to navigate maybe needing a higher level of care at a nursing facility or dealing with their insurance. And this is something we also can support. And then lastly, spiritual and existential distress. This is probably the most intimidating to address as a physician, to be completely honest with you. And it's because we don't get as much training in this, but it's looking at the deep questions of meaning and value and identity, which it sometimes can be affected by a serious illness. And this can affect people with or without faith, but it's those big questions like, where is God in all of this? And why is this happening to me? And it can make the patient really have difficulty in trusting their healthcare team, or it can just have them really impact their relationships with others. And it's these kind of issues that can sometimes draw people to want to prematurely hasten their end of life. And that's something that I personally feel is just so many reasons why we need to address this and really walk with and accompany these patients through this. And so how do we address pleas for hastening death? I mean, this is a huge topic, but I think it's important to recognize that where these pleas are coming from. What's the root of the distress? And my heart breaks for these patients, because to think about the amount of distress that these are coming from, we're a place of such despair. This point again of accompaniment, not leaving their side. I'm here with you. You matter to me. I see your value. And again, this is from the Samaritanus bonus document. Those who assist persons with chronic illness or in the terminal stages of life must be able to know how to stay, to keep vigil with those who suffer the anguish of death, to console them and to be with them in their loneliness, to be an abiding with that can instill hope. So is it ever okay to be involved in physician-assisted suicide or euthanasia? And I think you know the answer, but the Catholic Church has been consistently, vehemently opposed to this. And euthanasia is a crime against human life, an intrinsically evil act in every situation or circumstance. No authority can legitimately recommend or permit such an action, for it is a question of the violation of the divine law, an offense against the dignity of human person, a crime against life, and an attack on humanity. So euthanasia is something that we cannot be involved with at all, and any sort of relationship with it is called formal or immediate material cooperation, speaking ethically. So it's really breaking one's relationship with God when you think about the killing of life or being involved with that. There's no ambiguity. Each life we know has sacred dignity, the same value for everyone, and it deserves the same respect that we would give to one's own life. So when we think about palliative care, and we've been talking about that, what about hospice care? I get a lot of questions about this as well. And I think that it's important to realize that palliative care and hospice are distinct things. Palliative care is a big umbrella of care, and hospice is a subset underneath it, just to support and accompany specific patients who meet criteria, and I'll talk about that in a minute. So hospice is meant to be, this is again from Samaritanus Bonus, where terminally ill people are accompanied with qualified medical, psychological, and spiritual support so that they can live with dignity, comforted by the closeness of loved ones in the final phase of their earthly life. And again, hospice, nothing about it should be hastened. It's a hastening death. It's about accompanying and being with the patients, witnessing the end of their life. Often people think about the work we do kind of like being a midwife for the soul, just like a midwife accompanies a woman in labor, and we never know how long that process is. That's the same thing in hospice as we're nearing the end of life. And I show this graph, and this is also present in my book, to talk about the differences between palliative care and hospice. When we think about traditionally this top graph, where you had curative care, this focus on let's fight this illness, let's do everything we can. And then at some point, the doctors just tell the patient and their family, there's nothing more we can do. This is a very jarring and often grief-inducing situation because the patient was not prepared at all. And we're all mortal. I mean, this patient may have had an incurable disease for a long time, but this never was really discussed. On the other hand, if right from the diagnosis, as the patient is still fighting for cure, we have palliative care support. So you see that in the blue on that second graph. We have this, not even like they're that present, there may not even be that needed, but the patient knows there's a team for support if they have more symptoms, if more stresses come up. They may not need them, but the patient over time might develop more needs, and the team is there to walk with them and alongside their other doctors, until it might come to some point when the patient says, I know this is incurable. I don't really want to keep going back and forth to the hospital. I'm ready to focus on feeling as comfortable as I can, being with my loved ones, spending each day the best I can with focusing on the quality that I have. And that's the time when you really have these conversations if hospice makes the most sense. And that is when that shift from palliative care to the hospice subtype of palliative care can make the most sense. And so it's meant to be a very smooth transition and something that is very supportive to the family. And so a question I often get a lot is there an obligation as Catholics to aggressively treat? Like if you have a serious illness and your doctor offers you, let's say, chemotherapy for your cancer, do you have to say yes to it? And if that chemotherapy fails, do you have to say yes to the next one? Like there may always be more options, but what do you get to do as a patient? And traditionally, you may have heard of the terms ordinary versus extraordinary care. Ordinary being basic care, extraordinary being like a little bit extra or a little bit more than necessary, the basic. But we kind of got away from those terms, and we now use these terms proportionate care versus disproportionate care. And I like to use this picture of a scale here, because what we do is we take a decision for a patient. Let's say it's chemotherapy, and we say, all right, in the eyes of the patient, does the benefit outweigh the burden of this chemotherapy for the patient? Proportionate care means the benefit outweighs the burden, whereas disproportionate care is the burden outweighs the benefit. As Catholics, we believe and we teach that if something is truly proportionate, we should choose it. It makes sense. The benefit outweighs the burden. Definitely, let's do this chemotherapy. It's going to help my cancer. I'm going to feel better. I'm going to live longer. But sometimes for particular patients, the burden can actually outweigh the benefit. Maybe the patient gets so many side effects from that treatment. Maybe the cancer isn't really being affected by that. Maybe the patient just knows this is like, keeps bringing them back and forth to the hospital, and it's just becoming overly burdensome. This is so hard. You do not have to choose something that is considered disproportionate care. And so it's tough, but if you can kind of take this principle and apply it to your situation, it can really look at things like dialysis. It can look at things like going on the ventilator. It's really looking at these decisions in light of each person's personal situation and preferences. Another thing we do in palliative care is we help people through advanced care planning. And I believe for Catholics, this is another thing that is important because we're looking at facilitating meaningful conversation for things like advanced directives, where you're communicating about your personal values and preferences to the rest of your healthcare team. And as you have these conversations, I kind of say we're hoping for the best through everything, but we're preparing for the worst. We're knowing that things may happen in the future that I don't want to happen, but this is how I want to be prepared for it. This is how I want my loved ones to know what I think about them, and then my healthcare team to also know. And so when we're looking at advanced directives, it really is not just a one-time like checkbox. It's a conversation, ideally including the doctors that you're most comfortable with, that have cared for you the longest, and those others that are involved in your life, like your medical durable power of attorney or MDPOA, your family. And it's particular to your own situation. So every conversation about advanced directives is unique. It's looking at the patient's medical situation, making sure that they really understand it, and then looking at the treatments and options that they have in light of the patient's values. And again, that proportionality, so the burden versus benefit of those options in the eyes of the patient. I have a link here to something called the Conversation Project, and it's just a nice guide that's available for free online that can help families kind of start to talk through these conversations, because they can be a little daunting, I know. I mean, these are things that I often have in the hospital with patients and their families, but it's really nice if you can have it before you go to the hospital, before any sort of crisis happens. The goals of advanced directives are really looking at communicating any potential medical decisions that lie ahead. They're looking to honor the religious and ethical beliefs of a patient and communicate any other values or preferences the patient has regarding their health. So it's really important. Like it might be, I really want to die at home, surrounded by my family, or I might want to be just really out of pain. Like that's really important to me. And when you think about advance directives, we don't want advance directives to tie someone to a decision that might accidentally commit them to refuse something that really could benefit them, or to commit them to something that might really not help them. So when I'm filling these out with patients, I really try to avoid things like, no matter what, I don't want to ever be connected to a bunch of tubes, or I don't want machines breathing for me, or do everything and anything possible to keep me alive. Because these statements really are not that helpful in the setting of a true context of medical situation, because there will be some times when things like tubes or ventilators could be really helpful to a patient and maybe get them over a hump and get them back to their normal health. And there might be times when these are just really not going to be beneficial at all. So it's a process where I try to help people, kind of guide them. We want to be open-minded, but we also want to give direction, which I know it's hard, but a lot of the forms out there are tough, and sometimes you might have encountered one with your doctor or a loved one that has a checkbox system. And these forms aren't necessarily wrong or unethical, but they can have the opportunity to limit patients because we aren't checkboxes ourselves. And I would never want someone, because of a checkbox, to like not get care. And I'll tell you, as a doctor myself, I tend to use these forms as a guide, but sometimes in difficult crisis situations, someone might receive this form in the ER or something, and then it would direct whether or not they give certain life-sustaining care. And so it's really important, as we thoughtfully and prudently we carry these forms out. I think as Catholics, one of the most important advance directives to have is a medical durable power of attorney. And this is someone where if you ever could not make your own decisions, so if you were in a situation where you were confused or sleepy, or you were on a life support machine where you could not speak for yourself about what you wanted for your medical care, this would be someone who would speak for you. This is someone who really you need to trust. And it needs to be someone that you tell before this crisis happens what you would want, that you've actually had conversations with. They need to know your values. They need to be easily reached by the medical team. And they need to be able to like emotionally separate from you and to be able to say, yes, I love you, but I'm not going to make decisions that I want for that person. I'm going to do what they would want, what they would think, what they would do if they could speak for themselves. I'm here to follow their directions. That's who you want to pick as your medical durable power of attorney. And as a Catholic, it's important to pick someone who knows your beliefs, knows that your beliefs are important to you, and can help advocate for those in the setting of the hospital. So I think that's something that I would just think about when you're looking into this. So for Catholics, all advanced care planning documents, this is just a quick little list that was from an article that I highlight in the book, but just stating things like pain should be managed well, like trying to, like I mentioned earlier, keeping us as alert as possible, but out of pain, doing things that are proportionate to our care, rejecting prematurely hastening death, the sacraments around the end of life, those kinds of things are just very important. And so in the last few minutes that I have, I'm just going to go through a few slides that really share when is it appropriate to get palliative medicine involved. And I think if you're thinking about yourself or a loved one, and maybe they're in the hospital a lot, maybe they've got a lot going on medically that probably would not be harmful to just bring it up to your medical doctors or your loved one's medical doctors and say, hey, could palliative care be helpful? Could you refer me to a palliative care doctor? Could you connect me with someone in my community? So anyone with a new diagnosis that's just floored you because it's like so intimidating of what's all happening, or an illness that's just worsened over time, if you have a lot of stress in your life, maybe a lot of symptoms from your disease, a lot of pain or shortness of breath, nausea, if you're having a lot of conflict between your healthcare team, you don't feel peaceful with the plan, or you're not understanding the plan, that could be helpful. Or if there's any sort of existential distress or those bigger questions like I was talking about, we're specifically trained to help work through this and support you. What could you expect from palliative care as we accompany you from a consult? You might get medications to help with pain or symptoms. You might be connected with community resources. You may find that the type of palliative care you need the most is hospice, so they connect you with a hospice team. But palliative care is never about hastening end of life. It should not be about pushing any agenda on you. Palliative care is here to explain your options, understand, and then help make sure that you are taking your choices in front of you, looking at your own personal values, and then making the best decisions. So we're helping just to be on your team. So providing spiritual support, we have chaplains on our team, working through distress meetings and meeting with other people in your care team, kind of coordinating care. Those are all sorts of things that palliative care can do. And there are many myths out there about hospice that I highlight a few on here. And these are things that come up to me pretty much weekly, at least in the hospital. So many patients feel that hospice is a place, it's somewhere you have to go, and really hospice is a care service that comes to wherever you want to be. Some people worry that hospice is only for right at the end of life, and it's really not true. Hospice is appropriate, again, when you have goals that are consistent with more of a comfort-focused approach rather than a disease-fighting approach, and you're ready to kind of pivot to focus on less time in the hospital, less time getting more chemo, but more time focused on feeling comfortable, getting symptom management, and being where you want to be. And so that's when hospice makes sense. If you don't really have that kind of mindset and your disease is not that severe, it doesn't really make sense to be on hospice. So it's really just for particular situations. But I tell people, if it makes sense for you, get it, because sometimes you can get it and you actually find that you live longer, you live better because you have a lot more support coming to you. And so these are just a few things about hospice and things that I have found over the years. Now, I think that a lot of things that come up for me in my talks are about some of these unethical practices. And earlier in the talk, I spoke about hastening of death and things like assisted suicide that have passed in several states. And I do think it's important to note that there are people in every field of medicine that are not safeguarding the dignity of life. And I think that's important to know as patients. And we, unfortunately, in our world today, cannot assume sometimes that there is a pro-life kind of focus to each physician we have. But I think there's ways to safeguard against things. And just like in every field of medicine, there are people in every specialty who are practicing in ways that are not consistent with our church teaching. There are obstetrics and gynecologists who are focused on celebrating abortion. And there are people in my field of palliative care, very sadly, who are celebrating assisted suicide and euthanasia. But there are those of us fighting for life in this area. And so we must advocate and educate about the good, true, and beautiful of palliative care and about walking with patients and accompanying them and really educating others to champion this kind of care. And so these are things I just wanted to highlight, but to just be on guard, because you and your loved ones, especially your loved one who may be dealing with serious illness, they're in a very vulnerable point in their life. And we need to make sure that we support them and advocate for them, to say that, we really value the sanctity of their life and we don't want to do anything to impact that. The last three popes have all written that palliative care is a beautiful thing to support. That the Catholic Church and the Catechism actually says that palliative care is a specialized form of disinterested charity. As such, it should be encouraged. And so it's really been wonderful for me to learn more about this as a palliative medicine physician and how this work can be tied to our faith, and so to share it with you. I really believe it is true accompaniment, and it's working at optimizing human flourishing. I say that your disease doesn't define you. I'm here to walk with you and to keep you living the best life you can for as long as you can. Many people that I care for, the world might say, well, you don't have productivity anymore. What are you doing for the good of anything? The world might see them as a burden, but no, we work to elevate the dignity of that person, to say that you matter. Palliative care is working at radically loving. This is the kind of mentality we want to have, and loving each patient, as opposed to assisted suicide that destroys that therapeutic alliance inherent to medicine. Palliative medicine really wants to emphasize patients' intrinsic dignity. I really believe that it's the antidote to the assisted suicide and euthanasia movement, and it needs to be the Catholic response, because it's integrating medicine and modern technology. And we need to advocate and champion this. This is the way end-of-life care should be practiced. to accompany people and not abandon them. I think assisted suicide is the ultimate abandonment. Each patient that I care for is someone to love, not a problem to treat. And palliative care is really helping to understand individuals' values and beliefs, to use them to help inform medical decisions, to remember that this person is willed into being and loved by God, created by Him. And what a gift it is to be with this patient and their family during this time where they might be nearing the end of their earthly life. So in closing, as a palliative care physician, I feel one of my responsibilities is to work to help reinstate meaning into a patient's life where they may observe it to be absent, where this disease may have stolen from them. I don't have an agenda, but I work to understand the patients. I help to restore dignity and how, despite significant debility, patients can continue to generate positive activity in their life and impact positively the lives of others. And I hope this talk today has helped impart the gravity of some of these issues facing the end of life and some things that I feel you need to know as informed Catholics. Respect and reverence for the lives of people seriously ill and dying, it really spans the spectrum. I mean, it's a pro-life issue, but it's a social justice issue. It's a human rights issue. And it's important for us all to know about, because we all have opportunities to fight for the dignity of life at the end of life in your workplaces, your neighborhoods, and in your families. It's about seeing people as the gifts they are, not burdens. It's about having special reverence for the handicapped, the elderly, and the sick, anyone who is vulnerable. It's about not fearing suffering and letting others who you know are suffering know that they matter and that you're with them and that you will not abandon them in what they're going through. And as we continue on our journey of this mortal life and as we accompany others, may we always remember our Christian hope. It gives us true courage. We cannot be afraid of our futures, of suffering, or of death, for we live in the redeeming love of Christ. Thank you so much.
Thank you, Natalie. I will give you a moment here to catch your breath as I invite those on with us to submit questions to Dr. King. And I've already got a few things coming in here. Thank you, Dr. King. This is beautiful. It is applicable to not only Catholics, but all Christians. I particularly like the image of a beautiful sunset alluding to a caring and cared for path to our next destination. I think that was very well put. Yes. So let me ask you, as we're waiting for some more questions to come in, is there a directory of Catholic palliative medical doctors that people could access?
You know, I wish. That would be great. We have organizations like the Catholic Medical Association, or which can be accessed at cathmed.org, and you can look for a physician in your area. You also could reach out to your local diocese and ask the director of pro-life, and often it's like pro-life, family life office. You can say, do you know of any supports locally that would be respectful of end-of-life care and really honor our church teachings. And then honestly, your being open about your faith, if you have a palliative care team, should be very standard, that they respect any value system and any faith base. So they should have readily access to a Catholic priest, for example, if you're on a hospice or different things. And I just think being open about it is always great if that's important to you.
Mm-hmm. And I don't know if you can answer this question, but I assume you have some knowledge. Do most insurance companies cover this kind of medical care?
Oh, yes, that's a great question. And it's a question I get a lot, actually, because people may not have heard about it, or at least for me, like, it wasn't really that common when I was growing up. I didn't know about it too much. And yes, it's just like any other medical specialty. So like how you might go to a cardiologist or a kidney doctor or cancer doctor, it's just the same thing. It's another medical specialty that is covered by insurance. So palliative care clinics or time in the hospital should all be covered, no problem.
Okay. And then you were talking about the advanced directives, right? And some of the forms that are just check boxes and can be limiting or maybe misleading. What would be your suggestion for people who encounter that?
Yeah, so I think as you fill them out, it should be filled out with someone who really knows you and your values. So it should be like your primary care doctor would be an excellent person to complete one of these kind of forms with. Sometimes I find that patients in a nursing home setting might be, they might have a nurse's aide or something fill them out who's never really known the patient. And these might be just signed by a doctor later. So what I would do as a loved one is say, I'd like to hold off and wait till her doctor can be here, or something like that. I think is one way. And then as you fill them out, I would try to fill them out with the context of your own situation, and I would leave things open ended. So sometimes there's like a part, and I don't like this. A lot of times different states have certain things on there that aren't even applicable to a lot of patients, and I just say just leave it open ended. Like, yes, if I need that in that situation, I'd be open to it, or try a
Okay.
trial of it or something, because then you're not blocked out. And we shouldn't view these as super black and white, but I fear that sometimes they could be perceived that way.
Mm-hmm. I guess also having somebody there who can explain it to you, right, in normal
Yes,
language. Yes.
really helps, because
Okay.
the forms themselves can be very confusing.
Right, right. Here's another question. Does Medicare cover palliative care for a limited time or up to 6 months?
Yeah, so that 6 months is often what people think about the Medicare benefit of hospice. And so when we're thinking about palliative care, it doesn't have a time frame associated with it. So you don't have to worry about getting it for a particular time. If you are needing hospice, that type of palliative care, then often you have to meet certain medical criteria. That medical criteria just indicates that your disease is severe enough that historically the doctors would think you may die within 6 months. Now, that is not really that relevant anymore. Patients get recertified every, I think, 90 days on hospice, and they can, if they still meet criteria, they just get on again. I mean, I've known patients who've been on hospice for years. So I think if you feel that hospice could benefit you, you could get evaluated and see if the service would help you, and you don't have to worry about, oh, I only have 6 months of it. Just know that
Mhm.
it's that's sort of a misunderstanding often.
Okay. Okay. So if we could put ourselves in the position of a leader in a parish secretary, and they are told of a serious illness, right? One of their parishioners. What would you recommend be their response, or maybe a series of things that could happen?
Well, I mean, if the parish is able, I think having someone just kind of reach out to this patient and their family to just check in on them, seeing at what's going on, if they're having access to medical care, do they have rides, do they have access to getting their medication, like do they need extra support, like what's going on at home, and then helping support them. And maybe there's parish volunteers that could visit them occasionally if they're going through a lot more, people that could help them get groceries or meals occasionally, or bring them communion. All those sorts of supports can really be very impactful. Um, and then if more things arise, I mean, helping support this loved one, especially if they're like kind of lonely or don't have a lot of family. I mean, it would be amazing if someone from the parish could maybe go with them to appointments or something like that. But just sort of a support system in place, or even a check-in. Maybe you have a little checklist of like just seeing that, does this patient have all these needs met? That are common, so that no crisis happens, or we can be that support net for our fellow parishioners if needed.
Right. And using that whole thing of accompaniment, right, with them. Yeah. Yeah. Other health, does Medicare cover home health aides in the home with palliative care?
So I think often at that palliative care can have often has a social worker on the team that can help get a home health aide into the home. Often it's for a specific time frame, and they can help work to see if your insurance would cover that. And if you need it longer, they can work with you. Sometimes patients will have to end up getting like private pay support over time, but I would really lean on the social worker that should be associated with palliative care to kind of help work through those distinct care needs.
Hmm. And that's part of the team, right? The social worker.
Yes,
Hmm.
yes.
Yeah. Yeah. And I don't know, maybe you answered this already, but maybe something you can add. As a priest's family member, what might be some of the best ways I can help other families reduce their anxiety around my father's care and end-of-life decisions?
Well, I think a lot of it is just education. It's helping people not be afraid. Um, Sometimes I have people come up to me and they're really afraid of hospice. They feel that they've heard stories, and I've heard stories too that make me so sad because people hear things that hospice killed my family member or did something. And what I would say is get your family together and have someone from the hospice meet with you and be really honest with them about your negative experiences or your fears that you have. Maybe have a list ahead of time and just share with them, like, I'm Catholic. Our loved one is Catholic. We really value the sanctity of life. We don't want anything to happen like that hastens their end of life. We cherish this time with our loved one, and we are really happy also to have this needed support of hospice. But we just want to help understand that we can work well together. And so little things like how hospice may change medications or start a new medication or anything that they may do that might be different is just good to be in communication with, so that you understand why they're doing things. So you're not feeling really scared or worried that something is being done to your loved one, because it really shouldn't be. That's really not the aim of hospice. And so I think a lot of these fears can be mitigated through just good communication.
Absolutely. Well, this has been really helpful and so informative. I wonder if you could talk to us a little bit more about your book that you alluded to,
Oh, yeah.
Intensive Caring. Yeah, tell everybody about it, how it can benefit them, how it can help.
Yeah, so I wrote this book because of the many questions that I've received in my years of speaking and helping patients at the bedside. And I really had in mind the patient or the loved one of a patient who is just trying to navigate the healthcare system, also as a Catholic, and really helping them not be afraid, of end of life care, but also to know how beautiful it can be and to really work through a lot of these difficult scenarios. And so the book is divided into chapters that deal with different aspects, some of the things I mentioned in the talk today. And I used patient cases to help explain. So common scenarios and common questions, and really try to help look at the stress that's there and help to mitigate it. So this is really there to be helpful. And I think it can be something you read it straight through, or you just go to the chapter you need and the issue that you're dealing with. But it's meant to help reduce the stress burden around serious illness.
Yeah, and something that can be looked at before a loved one is seriously ill, or before that might be yourself, right? To be informed ahead of time, as much as possible.
Yeah, we want to help reduce any crisis. I think whenever I see a patient in the hospital, it is a crisis. Like, you don't want to be in the hospital. You don't want to have had a lot happen. And especially if you've been able to talk through things ahead of time or get supports in place, it makes a huge difference. And so I want you just to be as supported as you can.
Yes. Another comment here. Thank you, Dr. King, in teaching this very valuable information, helping with the information about the needs of people in their care. Book is great so far. Wonderful. We got a testimonial there. Awesome. Well, I really appreciate you taking this time out of your busy life as a doctor, as a mom, and all that you do to share your expertise with us and to help us support our loved ones at this difficult time and know what we can do and what is available out there. It really is very, very helpful, so we can live according to our faith and our values. So thank you so much. And for all of you with us today, you can get 15% off the book when you order at AveMariaPress.com using code webinar1112 for today's date. Thank you, everybody, for sharing this time with us. And I hope that you can join us next week. Mark Hart from Life Teen, also known as the Bible Geek, is going to talk about how to really create Bible study, small group studies in Scripture that succeed. He's done this for a long time and knows those things that don't quite hit the mark. And so giving us some of those tips and strategies. So hope you can join us for that time. All right, everybody. Thank you so much. Thank you again, Natalie. Have a great week, and we'll see y'all soon. Bye-bye.